Time for some clinical peanuts.
Is not ready for that. So allow me to please speak on something which I slightly tweaked for today's talk, which is toric IOLs, and I thought that would be interesting as well. So I think I'll take that up today. Does anyone want to start off with telling me what this title means to them, Anuj? What the three dots are on either side? It's related to the lens.
Yeah, anyone from the audience, anyone would like to take?
Has anyone seen a toric IOL? So toric IOLs usually have these three dots on either side of the lens because these three dots help us align the lens to the axis in which it's intended to be. So the title of my talk, which I had kept, was Connecting the Dots, because everything that lies between the dots is what we're going to talk about today. So we'll get started. So I thought I'd just start off with a couple of cases which came to our clinic. The first was this 55-year-old female housewife who was seeking treatment for her moderate grade cataract in the right eye. She had an average axial length in keratometry, nothing immediately jumping out of the A scan. And her keratometry, you can see, was not something which was very striking. It was around 0.23, her average keratometry, and the Ks were relatively in the normal range. Given this low level of astigmatism, most of us, and I would say, if you might permit me, that it would not be necessary to implant a toric IOL, and most of us would consider either just sitting on the steep axis of this patient, which over here you can see is somewhere around against the rules, or around 160 to 180. So we would probably sit temporal in order to correct the small amount of astigmatism, and I'm sure she would have an absolutely good outcome. So the choice of IOL in this case would have been a monofocal IOL with us sitting on the steep axis. This second case is slightly more different, where again axial length keratometry is nothing too abnormal. But you can see that the total amount of keratometry for this 65-year-old female patient in the left eye was around 1.88, and the TK value, which we'll come to sometime later in this presentation, was around 2 diopters at around 90 degrees. So her steep axis was at around 180, which is something we commonly see in the elderly age group, that they mostly have an against the rule astigmatism. And since the cylinder was significant and she did want to be spectacle free, at least for distance, we decided that the best course of plan of management for her would be to implant a toric lens. And this is how we did the calculation. And the lens we implanted in her was a T5 lens with a very minimal residual error. And this is again something I will talk you through in the rest of the presentation. And she had a very minimal post-operative cylinder of just hardly 0.16 degrees, but with the flipped axis at 88. The third case is this 40-year-old office worker who is a very demanding patient, has an early cataract. Again, regular case with a regular axial length. But you can see that the amount of cylinder he has is not very significant, but also not very insignificant compared to the to what the first case was again. He was a slightly more demanding patient in that he wanted to be spectacle free. And so an EDOF lens was planned in him. And since we were planning a premium lens, we wanted to ensure that he was spectacle free. We decided to go in for a toric lens. And this is although a low power of toricity that was selected, that is a DFT 315. This gave him a very low estimated postoperative cylinder of just 0.05 at 14 degrees. So these are just three cases that I thought I'd start off with, which shows the spectrum of range of different decision making in toric lenses, and what where we can start off with and what we can reach when it comes to planning these kind of cases. So I'll just briefly touch upon why toricity is relevant. It's because in a large study conducted by in the AIMS group by Dr. Sharma and her team, they found that around 60% of the eyes had corneal astigmatism of less than 1 diopter. And 40% of these eyes had a cylinder of more than 1 diopter, and they concluded that if a large proportion of these patients, especially in the older age group, had a high cylinder, they would benefit, and there was a scope for correcting toricity in such patients. Now, why should we correct it is because the quality of vision essentially in a patient without any astigmatism and even with one diopter of astigmatism is significantly and drastically different. This is uncorrected vision. And as the astigmatism increases, it is also known that the contrast of these patients decrease, and therefore it begets the question, how much of a cylinder should we actually correct? So the minimum amount of cylinder that should be corrected, and which is a subject of much debate, but which this one paper touches upon, which says that astigmatism of less than 0.5 diopters did not degrade visual acuity, but suggests that on a clinical and case-to-case basis, the correction of astigmatism of less than diopters should not be considered. But again, this is something which is subject to on a case-to-case basis, which we correct, and this is something we'll discuss again later. So the various methods to correct astigmatism are many. You can either, as we saw in the first case, sit on the steep axis, which is on-axis incision placements when you are planning phacosurgery. You can combine your phacosurgery with limbal relaxing incisions or LRIs. You can plan a toric IOL. You can plan top-up procedures after you've done the surgery in order to correct the residual error which may be present either in the form of any laser vision correction, and of course you can offer the patient glasses after surgery as well. So, something on axis incisions. This is something that the patient and most patients in our older age group have against the rule astigmatism. Sitting temporarily helps usually correct a small amount of that small cylinder. And if it is something a little more, say around 0.5 to 1 diopters or even sometimes 1.25 diopters, you can consider a limbal relaxing incision as well. So a limbal relaxing incision is quite easy. It's basically this corneal incision which is made at the limbus. There are various ways of doing it. You can do it either manually or using a femto machine. A femto machine is of course much more expensive, and therefore manually performing it with a guarded blade, either a simple guarded blade or a diamond blade, is something that most cataract surgeons practice. These LRIs are dependent on the corneal thickness, on patient age, on the white to white of the cornea, on various other parameters, and therefore it's very difficult to manually calculate this. Therefore, there is an online calculator that a lot of us have access to, and it's freely available online, called the LRI calculator. This basically uses the normograms which have already been set in and placed. All you got to do is enter the patient details that's for, and it spits out this image which allows you to manually mark and to place these LRIs. Either you can make one LRI or two opposite clear corneal limbal relaxing incisions. A rule of thumb, if you don't want to go and do all of this for every patient, is that approximately 1 clock hour of paired incisions will correct around 1 diopter of astigmatism, and 1 clock hour is around 30 degrees. So anything up to 1.5 diopter is be corrected by LRIs. There are two common LRI normograms which are available. One is the Donfield normogram and one is the Nichemin nomogram. Both are available online, and the Nichemin nomogram is age and pachymetry adjusted. So it'll appear here like saying NAPA. And both are easily available online, and both are equally good. So if LRIs, the problem with LRIs are sometimes that they do tend to regress, and they are not as, say, accurate and reliable as toric lenses. And therefore, if you have a slightly larger amount of cylindrical error, you might want to consider placing a toric lens. So toric IOLs we will cover under the clinical examination, the biometry, and of course the IOL power calculation for these lenses. Now, most cases of regular astigmatism are suitable for toric lenses. There are some, not absolute, I would say, but relative contraindications to placement of these lenses. One is, of course, any absolutely irregular corneal astigmatism, because getting a keratometry value to place in your calculator might be difficult in such cases. Any cases where you anticipate that the zonules are weak or the pupil is small might create surgical problems for you in placing the lens and the stability of the IOL post-surgery. any case like this, like a polar cataract, where you anticipate that there is a likelihood of the PC tearing. So in these cases, we under promise and over deliver. And therefore, even if you keep a toric lens on, it's best to always have a monofocal lens as a standby. High myopes, again, are a relative contraindication because they have large bags and weak zonules, and sometimes these toric lenses tend to rotate more in myopic patients. Any cause of progressive increase or change in cylinder, such as this advancing pterygium, might again be a contraindication to placement of a toric lens. And these hard cataracts with small pupils and weak zonules are again relative contraindications to placement of toric lenses. Now, another not absolute, but again, something which has to be thought about prior to placing toric lenses is the angle alpha. And I'm sure a lot of you all have heard and read about this in multiple videos online. Basically, angle kappa is what we consider for laser vision correction, and angle alpha is what we consider when we're placing these premium toric lenses. Angle alpha is basically the angle between the center of the limbus, that is these two blue lines, and the visual axis, which is this red cross. And theoretically, it's stated when this angle exceeds 0.5, that the center of this capsular bag, which is essentially what this limbus to limbus is a surrogate marker for, and the visual axis, which is essentially the line of sight of the patient, may not be coinciding with each other. And therefore, a very large angle may result in decentration of this toric lens, resulting in suboptimal visual outcomes. And therefore, it's said that this angle alpha has to be taken into consideration prior to planning toric lenses. But this is not easy to measure, especially in people who don't have access to multiple topographers and high-end biometry machines. And therefore, this per se is something to be kept in mind, but not an absolute contraindication in my mind. The second thing that we have to talk about and consider when we're planning toric lenses is biometry. Biometry is essentially of two main things: axial length and keratin. Now, most optical biometers are typically sufficient for measuring axial length, and even immersion biometry can become very useful, especially in these hard, dense brunescent cataracts. But what is more important in toric lenses is, of course, keratometry, because this is the single most crucial parameter for calculating toric intraocular lenses. And what was found in this one paper by Osher, nevertheless quite an old paper, I would say, in 2014, when we didn't have very many advanced methods of biometry like the latest biometers that we have now, there was that what he suggested was that average measurements across various keratometry machines might produce better outcomes in your keratometry readings, and especially when you have a number of outliers which may confound your keratometry readings. And therefore, he said, if you do have access to multiple machines or technology, that might help you produce better outcomes. But I think with the advances that we have in biometry nowadays, this may have become to some extent redundant. The conventional indication for toric lenses is a dioptric cylinder of around 1.5. However, if you're considering premium lenses, what most surgeons will do is consider lower thresholds of correcting cylinders. That is almost, they might go as low as 1 to 1.5 diopters as well. Most standard IOL powers are available in a range of 1.5 to 6 diopters, which can correct the astigmatism on the corneal plane of around 1.03 to 4.11. And I'll show you the table of what various company lenses offer in various ranges. The thing to remember over here is that only up to 6 diopters, at least for the Alcon and the J&J Technis lens, is corrected by the lens itself. And if you have very high cylinder powers, there are companies, especially the customized toric lens by the Care Group, which can now correct, I think, even more than 15 diopters of cylindrical power, as these are highly customizable lenses. So the calculator, which is now most commonly used, is the Barrett toric calculator. It's quite a straightforward calculator. All you have to do, this is exactly what it looks like. This is a screenshot of a calculation. you feed in the surgeon name, your lens factor, or the A constant, and you feed in the lens that you want, the flat steep axis along with the keratometry readings, the axial length, anterior chamber depth, the target refraction that you desire, where you're going to place your location, and how much your location is going to induce a flattening of, the lens thickness and the white to white. And essentially what you do is say calculate, and if you click on Toric IOL, which is this option here, what it gives you is the lens power using the Barrett calculator of what it thinks is the best spherical power as well as cylindrical power lens that you should be placing in the eye for the least amount of spherical equivalent. And it also gives you all of this data about what your target refraction is likely to be and how much of a cylinder plane, a corneal plane cylinder you're correcting. And what the advantage of using the Barrett calculator as against the Alcon and J&J calculators is it also calculates the spherical power of the IOL that you might give you the best results. The other thing which I thought I would just point out while I'm on the Barrett Toric calculator is that it gives you the option of choosing something called predicted PCA versus measured PCA. Now, PCA is something which we'll cover extensively today. It's posterior corneal astigmatism. Essentially, what the Barrett calculator does and what most of us select when we're using routine keratometry is this predicted PCA, because it uses a normogram to predict the posterior corneal astigmatism to give you this value and to give you the least amount of cylindrical error that you might have post-operatively. But it also allows you, if you click on this measured PCA, to go to this page, which is where you can actually enter the amount of posterior corneal astigmatism if you have access to these machines like the IOL Master 700 with TK, or the Pentacam, or the Galilei, or an OCT device which measures the posterior cornea directly, and therefore it allows you to directly enter these values to get a more precise reading of, to get a more precise measurement of the toric IOL power. One interesting study found that in most normal cases, not in eyes which were irregular or post LVC, was that when they compared the measured versus the predicted PCA, they found that the amount of error that was produced with both of them was quite similar, and there was not much difference between the IOL powers that were achieved using both of these techniques. So that brings us to what is PCA. PCA is basically posterior corneal astigmatism. And now it's something that everyone has heard about and is talking about when it comes to toric IOL power calculation, because failure to include this posterior corneal curvature can result in some amount of refractive surprise for both the doctor and the patient. So everyone sort of assumed that the power of the cornea that we were measuring on the anterior surface was the total power of the cornea. But now a lot of literature, and especially the work by Dr. Koch and his colleagues from Baylor, found that the amount of that the anterior corneal astigmatism is not a surrogate for the total corneal power, and that the posterior corneal curvature does contribute to the total corneal astigmatism. So most devices, that is most of your manual and automated keratometers, assume a fixed refractive index of something like 1.3375, because they assume a fixed ratio between the anterior and posterior surface of the cornea. But this has found to be not true, and we'll, as we go along, we'll see how. So something to take back and just to understand from this slide is that the anterior corneal astigmatism, as we all know, moves from with the rule to against the rule and changes with age. So when you're younger, you're more likely to have a with the rule astigmatism. As you grow older, that slowly shifts to an against the rule astigmatism. Posterior corneal astigmatism does not change with age, and it is roughly around somewhere between 0.3 to 0.5. The posterior cornea acts as a minus lens and creates a net power along the horizontal meridian, creating an against the rule astigmatism. So what that essentially does is something like this, that the posterior cornea tends to be steep in everyone, but has a net effect along the horizontal meridian and therefore produces an against the rule astigmatism. It does not change with time, like the anterior cornea, which can either be with the rule, against the rule, or oblique, but as we shift with age, as we grow older, shifts to an against the rule. What the posterior corneal curvature is an against the rule astigmatism, which usually stays stable with time. So this begets two kind of questions or two kind of scenarios. One where the anterior cornea has a with the rule astigmatism, say a young patient, but an inherent posterior corneal astigmatism, which is against the rule. So he's basically steep vertically in the front. That is, he has a with the rule astigmatism on the anterior surface. If you combine the two, basically the total astigmatism of the eye is actually less than what the anterior measured astigmatism is. And therefore, if your calculations are based only on the anterior with the rule astigmatism, without accounting for that posterior astigmatism, which is reducing the anterior with the rule astigmatism, you're likely, if your calculations are based only on anterior corneal curvature, likely to have an overcorrection. And if you, like in older patients, which we normally see, the patient has an against on the surface, that is, they're steep horizontally, and have an against the rule astigmatism on the posterior cornea as well, which is there in all people, which is what we said earlier. Then if your calculations are only based on the anterior, which is only that against the rule, where the total astigmatism is actually higher because the posterior cornea is also accounting for that little against the rule, you're likely to have an undercorrection in your IOL calculation because you've not accounted for that additional against the rule astigmatism of the posterior cornea. So in order to circumvent or navigate this conundrum, the Koch's group at Baylor Institute came up with Baylor nomogram, which they named, and basically it was to help surgeons improve their refractive outcomes with these toric IOLs. So basically, it is a reference guide for toric IOL implantation, and as per the nomogram, if the patient has a with the rule astigmatism, basically the threshold for a toric IOL implantation is shifted up by 0.7 diopters because, as we saw earlier, you are likely to you're likely to overcorrect if you have an anterior with the rule and a posterior against the rule. But if you have say a patient who has against the rule astigmatism, the threshold for implantation of toric IOL decreases. And so for the same T3 lens, which you might implant at a 1.7 diopters of with the rule astigmatism, the threshold might be as low as 0.4 for an against the rule. Now, this can be quite confusing, and it can lead to a lot of errors if you are manually trying to do this calculation. And therefore, thankfully, what the Barrett toric calculator does, especially when you put that predicted, when you click on that predicted in the box which appears, is that it applies this and helps sort of predict what the posterior corneal astigmatism is, and therefore sort of spits out a number for an IOL which you can implant in the eye. So that brings us to how we can use PCA. One is by directly using the Barrett IOL calculator. One is, of course, as we shown earlier, use the Baylor nomogram for in standard IOL calculators as well. And something which we now do at our institute, and if you have access to, which is the easiest and best thing to do, is use something called total keratometry, which is offered by the IOL Master 700. Now, as we saw earlier, the Barrett IOL calculator still uses a predicted PCA and did give you the option of doing the measured PCA, say from an OCT machine or a topographer. What the IOL Master 700 does is it measures directly, and it measures very accurately, the anterior cornea as well as the posterior corneal surface to give you something called a TK, or a total keratometry, which combines the anterior and posterior corneal surface measurements, so that it's a direct measurement of the anterior and the posterior surface of the cornea. And this is then this can be incorporated into standard IL power calculations. But what Graham Barrett realized was that if you use this TK value in the original calculator, which is already correcting for the posterior corneal astigmatism, you will have a double compensation, or you will have an overcorrection. And therefore, for the new IOL Master 700 using TK, he came up with 3 new formulae, which is the Barrett TK Universal 2, where you can use the total keratometry in routine calculations by using this Universal 2 formula. Or if you're making toric calculations, you can use the Barrett TK in toric calculations, and it gives you this in the final printout itself. And you can use a Barrett True K with TK in eyes which have undergone prior laser vision correction, where he has created this new formula where you can use this TK value directly in this formula in order to give you a final IOL power to be implanted in the eye. So, is there, after all of this, biometry, any role of topography? There's definitely a role of topography, because it helps you first know whether your astigmatism is regular or irregular. Regular astigmatism is very easy to correct with toric lenses, but irregular astigmatism becomes a little more challenging, especially in cases like this, where this is a pentacam report, which shows you it gives you this interesting chart, which is the EKR readings. Basically, what it shows you is the spread of the keratometry over various zones. And if you find that the keratometry varies greatly, it might be difficult to pinpoint on one keratometry value to enter in your calculations. And therefore, such patients may not be great cases for toric IOL implantation. On the other hand, if you're able to pick on a keratometry value which is almost say consistent throughout, then it might make a case like this suitable for toric lenses. Again, however, if you have cases like this where there are multiple peaks, say the keratometry is changing in multiple zones and changing a lot, or having multiple variations along various zones, then again it makes finding a mean K which you can use in your calculations difficult. And again, these kind of cases may not be the best cases for toric lenses. And in that way, these topography I find is very useful, when planning when planning toric lenses. So we cover the magnitude of IOL power, toricity, and axis, as well as the posterior corneal coverage. Something that I get asked a lot is about SIA, or your surgically induced astigmatism. Now, essentially, when you make a cut on the cornea, you're flattening that axis. And that is basically what we talked about, sitting on axis and LRIs. But basically, your phaco-incision itself, whether it's 2.8, whether it's 2.2, whether it's limbal, corneal, depending on the age of the patient, can induce or correct a certain amount of astigmatism of the cornea. And calculating it becomes very useful when you are entering your calculations for the toric IOL as well. So one way which I found, though I've not played around with it much, was on Dr. Hill's website, which is a very useful website for anything lens related. And most SIA calculators, what he states, are calculate only the mean magnitude of your incision. But what his calculator does is use a centroid method, means it calculates the geometric mean utilizing not only the magnitude of correction but also the axis correction, and therefore it's much more accurate in calculating the SIA. And it would be a good idea, especially if you're doing a lot of toric lenses, to look at what your SIA is like. More senior surgeons know that their SIA is around 0.2 for temporal, 0.3 for superior. They have a certain idea, but especially young surgeons like us, it would be a good idea to look back at our cases and see what our SIA is like. So finally, coming to what formula is best for these patients, and it has been repeatedly proven that the Barrett formula is beats all other IL power formulae, because not only does it account for the posterior corneal astigmatism, but it also takes into account effective lens position and the SIA, and that's why it's been incorporated into various online calculators as well. And what you can do is that if you do have access to the IOL Master 700, you can compare your Barrett TK toric calculations with the 700 with the online Barrett calculator using the regular case, and that also helps in planning your lenses. Basically, this is a great tool, the online Barrett calculator, for calculating lenses. The other thing which I said I would mention is the range of correction of these lenses, because this is sometimes something that is not does not always come to us when we're sitting in the clinic, and it's something important to be kept in mind because most of us use either the Acrysoft, the Alcon, or the Technis, the J&J. I have no financial interest in either of these companies, but most of us are trained and taught on these lenses and therefore use these lenses. But you'll note that the amount of spherical correction of these lenses is actually quite narrow compared to say what the Rayner lens is likely to correct, that is from -10 to +35 diopters as compared to just 6 to 34 of the Alcon lens. The Ultima Smart toric lens, again, as I said earlier, is a highly customized lens, and it is available for corrections up to 40 diopters of sphere, and if I'm not mistaken, even more than 10 diopters of cylinder now, and is a great lens, especially if you're planning cataract surgery in these very extreme keratoconic, PMCD, corneal scarred, those kind of eyes. Premium lenses, on the other hand, offer a much lower correction of cylindrical powers as compared to your regular lenses. The Eye-Hans, which is considered a monofocal plus lens, still corrects as much as the regular lenses do. That is a spherical power of 5 to 34 and a cylindrical power of up to 6 diopters. But you'll notice that the Symphony and the Synergy and the Vivity and the Panoptics all have a lower range of correction of cylindrical powers and only correct up to around 3.5 diopters of cylinder and nothing more than that. So the last part which I thought I'd touch upon is the methods of alignment, because this is something that becomes important when we're doing the surgery. So there are manual marking techniques, there are image guided techniques, and intraoperative aberrometry, which I personally do not have much experience with. Manual marking techniques are something which we're all quite familiar with and are all using quite often in our OTs. The issues, of course, with manual marking is marking the patient manually with a pen directly, either using the slit lamp, that is, you turn the slit lamp illumination to 0 180 and mark the patient on the slit lamp in the pre-op area, or you use a bubble marker, and I'll show you an image of that, and ink the bubble marker and then place those ink marks on the eye. The issues with this is that, of course, it has to be done in the pre-op area, and by the time you shift the patient from the pre-op to the OT, those marks do tend to fade or run off. There is sometimes a little component of head tilt as well, and some of these pen marks are quite thick. So a lot of now senior surgeons don't use a pen, but use sometimes a 26 or 27 gauge needle and mark the cornea. And this helps prevent them from fading and also helps reduce the errors that might be produced due to very thick pen marks, which sometimes can amount to almost 5 degrees of error. So this is what a bubble marker looks like. A bubble marker is essentially a marker with a bubble in the center, and the bubble inside the marker is influenced by gravity. So when it is centered in the chamber, it signifies that the marker is parallel to the ground. And the surgeon can use this to align the horizontal axis of the toric lens. And nowadays, there are a lot of smartphones which have come out for these high resolution ones with good cameras, because they have inbuilt gyroscopes, which basically allow you to align the toric lens. I know one popular one is the one which has been made by Dr. Saurabh Patwardhan, which is called iToric Patwardhan, which, if I'm not mistaken, is available only on the Android platform. There is also something called Toric Cam, which is made by Dr. Graham Barrett only. But again, I don't think that is available on the Android platform. I think it's only available on iOS. And both are available free of charge. So basically, what I've only sort of played around with Dr. Patwardhan's app, and what I understood is that it's useful when in situations when the slit lamp is unavailable. So basically, what you do is a freehand marking at 0 180 degrees at the limbus, and then you take a photo with the app. You align the circle in that photo, so this circle, to the limbus. And what it does is it connects these dots to a line, and then using the inbuilt gyroscope of the phone, it when you enter your intended axis, say that you had your intended axis of placement of the lens was 160, the app calculates the amount of error that might have been produced and gives you a new axis of placement for when the patient lies down in the supine position. So this is just a small video which I found online, which I thought I would put in here for everyone to see on pre-operative markings for toric lenses.
Surgeon requires to put reference and axis marking on cornea. The rest points of marker are inked using marker pen. Reference marking is done on 0, 180, and or 270 degrees using reference marker preoperatively. Anesthetic agent is applied on patient's cornea at this time. Reference marking is done in preoperative room with patient sitting in upright position to avoid any error due to cyclorotation. Cyclorotation is natural rotation of eye up to 7 to 10 degrees when patient changes from sitting position to supine position, and that may lead to imprecise reference and axis marking, ultimately resulting in undesired visual outcomes post-operatively. After placing these marks, patient is taken into operating room. Here, the surgeon places axis marks on the cornea, taking reference of 0 to 180 degree marks. Surgeon stains the axis marker using sterile marker pen, puts the degree gauge matching the rest points on marked 0 to 180 degrees, and marks intended axis of placement by producing 2 linear ink marks at 180 degrees each other. IOLs are inserted in the capsular bag using disposable delivery system, keeping the lens about 20 to 25 degrees away from final intended axis placement marks. Before placing the lens on final intended axis, surgeon removes OVP completely from the eye. Any residual OVP, especially behind the lens, could lead to undesired rotation of the lens after surgery, resulting into loss in astigmatic correction. Surgeon aligns the marks on IOL gently with previously marked axis on cornea to get desired post-operative visual outcomes. Before sealing the wound, surgeon compresses the lens to back of capsular bag to ensure that the lens remains in desired place.
Right. So that was just a short video to help everyone understand what these steps are for placing a toric lens
Surgeon
in the
requires to put reference.
The other thing is what are the various options for marking the toric, for making markings on the slit lamp. And again, this was a short video which was made by Dr. Prajakta, who is now a faculty at our institute on this. And I thought I'd just play this video here.
Various marking techniques, but the widely available and quick one is the slit lamp axis marking. Measuring the axis marks is equally important, or else this can cause improper placement of toric IOL intraoperatively and astigmatic surprise postoperatively. This for slit lamp marking, put an eye speculum after anesthetic eye drop with a sterile bud. Dry the inferior and superior, limbus and conjunctiva. Ink the marking ends of the toric axis marker. Make a thin slit beam passing through the center of the cornea at 90-degree axis. Mark superiorly and inferiorly. For measuring the axis, pass a narrow slit through the apex and center of the mark where it crosses the limbus. Here, the superior mark is at 90 and the inferior at 93 degrees. Areas marking
So, if you do want to avoid the discrepancies that do come with manual marking, such as the ink blots and the fading of the eye and the fading of the stain and the errors which can be produced with a thick ink mark, as well as all the errors that come with human manual markings, there is something which now the Zeiss system offers, which is that if you have the IOL Master 700 as well as the Callisto system, the Callisto Eye system in the UR, you can link the two, because the Callisto system has something called Z-Align, which is an eye tracking technology that overlays the previously captured image while biometry was being done over the live microscope image, and thereby allowing accurate and markerless toric IOL alignment. So essentially what it does is gives you these three lines, and you can align the three dots of the toric lens to these lines, and these lines move along with the movement of the eye, and makes marking quite streamlined and easy. So this also reduces the amount of error that you might have with manual markings. So this was sort of again proved in various studies, and one study here found that the digital tracking approach for toric IOL alignment was efficient and safe to improve refractive outcomes, and the image guided surgery helped to streamline the workflow in the refractive surgery, though I understand these equipments are quite expensive and might not be accessible to all. Manual marking also has stood the test of time and is quite an accurate and a good method of marking for toric lens placement. So another couple of interesting papers I found just before I end that I thought I'd mention over here was this one interesting paper which was published by this Japanese group on misalignments of toric lenses in 2017. And what this study found was that in the 72 Technis toric lenses they had placed, where they had marked the slit lamp with an ink mark and had taken digital photos immediately after surgery. They took photos very interestingly at R1, day 1, month 1, the third month, and a year after surgery, and found that misalignment, which was around 6.67, a mean of 6.67 degrees, was 28% because of the surgery itself. But the more misalignment, that is 61%, was because of the IOL rotation after surgery. And interestingly, they found that the IOL rotation after surgery was maximum within the first hour after surgery, and therefore surmised that the patient sitting up and walking out of the operating room and making slight movements, including eye saccades, could have contributed to this higher error, and noted that out of all of these IOL rotations, more than 85% were within that first hour. And this was quite an interesting finding, because it means that if your IOL is stable after the first hour of surgery, it's more likely to stay stable throughout the subsequent follow-ups. So another interesting and very large landmark study was done by Dr. Chang in America. And what he did was a sort of head-on analysis between the Acrisof and Technis lenses by Johnson & Johnson, Acrisof by Alcon and Technis by Johnson & Johnson, and was trying, and he's done equal huge numbers in both groups. And in his case, he used a digital alignment, that is, he used the Z-Align, which is incorporated into this Callisto Eye system. And he interestingly found that more than 10 degrees of rotation, which is a significant amount of rotation, almost a third of your toricity is lost when there's more than 10 degrees of rotation, was almost 3 times higher in the Technis group as compared to the Acrisof group, which was statistically significant. And he found that although the amount of repositions were not significant, that he accounted that for because not all the lenses that rotate are repositioned in OR, and therefore stated that although both IOLs had a good outcome, the rotational stability of the Acrisof toric at that time was much higher than that of the Technis toric, and this was the Technis toric 1, and the Technis toric had a predisposition to rotate counterclockwise, and there was a trend towards an increase in repositions with the Technis toric. And at that time, J&J took this quite seriously and decided to look again at why their toric lens was rotating so much, and they did change the version of the lens which we have, version of the lens which we now use is the Technis toric 2. Basically, what they did is they left the edges of the lens slightly unpolished. They didn't polish the haptics. Otherwise, what they did was polish the entire lens. And they now have this slight frosted surface, which increases the friction between the lens and the capsular bag. And this sort of frosted haptic enhances that static friction, allowing the lens to stay more stable in the capsular bag. And this has now improved the results quite significantly with these lenses. So I thought I'd sort of end with just pearls for a toric alignment when you're actually doing a surgery in the eye. And I'm grateful to my mentor, Dr. PVK, for allowing me to use this video. So this is a beautiful technique of marking the toric lens. What is done is a Mendes marker is used, and the previously marked 180 degrees is what the marker is again placed on. And what Dr. PVK over here is doing is he's already stained his MVR blade with a slight amount of ink. And because this produces a very narrow, thin profile, he's using this in order to mark the two opposite sides of where the lens should be placed. So there are various techniques of marking. You can either use the instrument which comes along with the gauge, or you can use a needle, or you can use any other instrument which is marked with ink, something similar to this, in order to get an exact marking which will stay put throughout the surgery. So the few pearls for toric alignment are to use a non-dispersive OVD when you're placing the lens, and of course to remove all the OVD that is behind the IOL, because otherwise it can cause misalignment of the lens after you remove the OVD. It can cause pressures to rise, cause the bag to get distended, and then also cause the lens to rotate in the post-operative period. Don't over-pressurize or over-hydrate these wounds, because again it can cause bag distension and IOL rotation. And basically try to minimize the activity that you're doing in the eye. Leave the IOL slightly undercorrected so that after removal of the OVD, you can finally place that lens and push it back into position, which is what we see here. And once that is done, the wounds are hydrated and sealed, and the IOL is tapped slightly to push it back into the eye, and the eye is closed. So if there is a re-rotation, say this IOL, which is here is actually the patient is coming back with a small amount of cylinder, then you may need to re-rotate the IOL again. One option is to use the eye trace, which has this Toric IOL enhancement software, which tells you that if your IOL is currently at this position, if you rotate it by X amount, you're likely to have a minimum amount of residual astigmatism in the eye. But not all of us have access to the eye trace, and therefore something which is easily available online, which has been made, if I'm not mistaken, by the Barrett Group, is the Astigmatism Fix software, which is a software which is freely available online, where if you enter the results of your lens and the current refraction that you have, it'll tell you how much to rotate the lens by in order to get the expected minimum residual error. Thank you so much. I feel like everyone has gone to sleep. No one is listening.
Everyone's astigmatism is corrected now fully, so
Yeah.
it's pretty clear and with good contrast. So
Okay.
we have few doubts,
Yeah,
but
sure.
a few of the doubts which have already been asked in the group, I'll just like to ask you that is, as a cataract surgeon, what do you feel, when is the right time to start toric in terms of number, or in terms of should we go for the post-operative astigmatism? This should we calculate our SIA? How should we go about going for toric starting?
So I think if you're starting out as a cataract surgeon, I think the first most important prerequisite is to be sure that you can do a good phaco. So if you're sure that you're confident of your surgical skills when it comes to phacoemulsification, I don't think there's anything that can really stop you from placing a toric lens in the bag, because it's essentially the same surgery that you're doing to in comparison to the regular phacoemulsification. The only thing is you need to rotate that toric lens into place at the end. So if you're sure that your phacoemulsification is producing good, reliable, repeatable results, I think that's good enough. And your biometry is accurate. You're not getting crazy post-op readings of crazy, errors in terms of your cylinder or spherical errors are off. Then I think once you've sort of set that into motion, you should be good to go for toric lenses.
Okay. So do you feel that one should calculate their surgically induced astigmatism before?
So honestly, I think it's great if you can. What I have seen most senior surgeons do is take around zero point 0.2 to zero point 0.3 diopters of error for their temporal incisions, which most of them sit on. If you can, and that is for a 2.8 millimeter incision again, which is made at the limbus. If you can, and if you have that, if you have, the pre-op readings, post-op, your final refractive error, how much your cylinder has changed by, what the size of your error was. If you can enter all that in, it's absolutely fantastic to do, but I don't think it should stop you from starting toric lenses. I don't think you need to calculate your SI before you start toric lenses. You can do it and it's definitely recommended to do it, but I don't think it's a prerequisite to start doing toric lenses.
One more question which was asked in the group is toric lenses in case of SICS.
Oh yeah, I don't have any experience in that. I have seen a few seasoned surgeons present their results of, it's a one-off case, like say a very hard brunescent brown black cataract and patient has a high cylinder, which you think you can correct with a toric lens. I think you should be, I don't think there's any harm doing it as long as the patient understands that the purpose of the surgery is not to make them 6 uncorrected, but to maybe reduce the magnitude of toricity that is there in their eye, and they may still require glasses after surgery for distance and near. So if the patient has understood that, and you sort of understood how much cylinder you're likely to induce with your 6.5 millimeter, or if you can in a smaller incision than that, then I think there's no harm in doing it, though it's not routinely done, and I per se don't have much experience with it.
Okay. Anyone, Rohan, you wanted to ask something? Rohan is there? Dr. Purva?
Yes, sir. First of all, thanks, ma'am, for taking this session and thank you for arranging it. And ma'am, I wanted to ask about the difference between the limber relaxation incision and the incision we give usually in the cataract surgery
Oh,
by input. So
so
is there any?
the incision that we normally give in surgery is your 2.2 or 2.8 or 3.2, whatever size incision you make. And that usually corrects something between 0.2, 0.3, 0.4 diopters of, it'll flatten that axis. So say you are steep at 0, 180, which is an against the rule, which is what most people have, then you are likely to reduce that error a little. You can circumvent it a little. And what some people do is utilize that to do something called OCCI, which is opposite clear corneal incision. So you make one more clear corneal incision on that same steep axis in the opposite side. But if you want to correct a little more and you want to do it in a little more precise manner, what you can do is an LRI where if you're say sitting on the steep axis, you can make an LRI in the opposite 0, 180 or wherever you're sitting in the opposite axis. Or if you're sitting superior, say, and you want to make an LRI along the 0, 180 axis, you can plan and do that as well. So there are two totally different incisions, though one is dependent on the other because you'll enter the amount of SI you'll create with your incision and where your incision is located when you're planning your LRI. So, but LRI honestly is not absolutely, they are great. People used to use them even in cases where there's no cataract as a refractive surgery, as a method of correcting small cylinders. But again, these are not very reliable because they tend to regress over time. So they are not very, and you can't predict how much of an error they might produce. To some extent, you can predict, but they're not as predictable as say toric lenses are, because it's ultimately a cut on the cornea which you're making, and you might not be sure of your depth, you're not sure of your distance from the center of the cornea. So all of that comes into play. I don't know
Thank
if I
you.
answered your question.
And ma'am, one more thing, I was just curious. So I saw some articles on the internet. They were using uh, fibrin glue for fixation of some multifocal IOLs of Technis. So can we use it on Toric or not?
You mean a toric lens for glued SFIOL?
No, not SF. They were using it in multifocal IOL of Technis.
Oh, that maybe Dr. Anuj will answer. I have no idea. I don't do SFIOLs. He does.
I think what you're talking is
PC
a
IOL, posterior
good
tubular IOL.
multifocal IOL, but we cannot use a toric IOL in that because you cannot rotate the IOL. Na? And you can theoretically, because then you'll have to make your incisions according to the axis, because generally we make them at 180 or maybe at 90. But that is, yes, theoretically possible, but I am not aware if anyone has done it or yeah. So maybe for exams or this purpose you should avoid it. But yes, maybe you can explore and tell us next time.
I've never seen anyone do a glued toric IOL, but I think sometimes we're just careful that the glued IOL has stayed there, that we're not bothered if it's a multifocal or a toric. So I don't know. If you find anything like that, please share it with us.
Okay, thank you, sir. Thank
Sir,
you,
this
ma'am.
is Dr. Amog.
Hello.
The question. Hello.
Yeah, let Dr. Purva go ahead, Dr. Amok. Then you can go ahead. Yeah,
Hello.
Yeah, please.
Yeah, good evening, sir. Ma'am, it was really a good session. I had actually two questions regarding toric IOL. One is, what is the minimum amount of astigmatism that we can usually correct with a toric IOL? As in, even if a patient has 0.75 diopter, can we offer him a toric IOL? And second question was, can you say something about the flip and anti-flip concept that is there, and how do we know in which patient we should go in for a flip or anti-flip? Like, can you share some clarity on that?
So 0.75, just off the bat, I might not really think about placing a toric lens because the patient might not see the value in correcting that small amount of cylinder with the toric lens. Though what I think is most lenses, and I can share that table with you, they start at around 1.5 diopters of cylinder, and I think the smallest amount of cylinder that is corrected on the cornea, let me check, was around 1.03 at the corneal plane. So I don't think anything lower than 1 would actually require a toric lens, in my understanding. You can correct it easily with an LRI or maybe, as we mentioned earlier, your corneal incision directly, though it might not completely correct. Your second question was flip, correct?
Yes,
Um,
ma'am.
so flipped axis is sometimes seen when we are trying to, a flipped axis is basically that the patient was at 0, 180 and now the very, very minimal amount of residual astigmatism after you place a toric lens is in the opposite direction, is maybe 90 degrees away. So what most surgeons would not like to do this or to go in for a flipped axis because they feel that patients might not be comfortable suddenly flipping around their axis. But what I feel and what I have read and understood is that because the amount of cylinder is so small, it sometimes doesn't really matter even if the axis has flipped. Because if you're getting if say with the regular, like let me just share my slides again. In the first or in the second patient, I think there was a flipped axis. One second, huh? I'll just directly share my, can you see my slide?
Yes, ma'am.
So this is a flipped axis when it shows you these two arrows. But you will see that the amount of residual which is left with the T4 is 0.4 diopters, which is much higher than the residual left with the T5, which is just 0.06, in spite of producing an axis which is 90 degrees away, a residual cylinder at 90 degrees away. So I would still go for the T5, which has 0.06 diopters of residual cylinder, rather than go in for the T4, which has 0.47 diopters of residual cylinder, but no flipped axis. You know what I mean? Does
Okay,
that
okay.
make sense?
Yes, ma'am. So we ideally would like to go in for the minimum amount of
Correct.
residual that is left, irrespective
Yes,
of the
especially if
axis.
this is so large. Sometimes the difference is very small, like this will be 0.06, that will be 0.07. So then you can go in for this one, But if the difference is so large, then you might still consider going in for this flipped axis lens. I don't think it
Okay,
should
if
be
the
hard.
difference is small, ma'am, then we should go in for the axis in which the patient already has the
Correct,
astigmatism.
correct,
Oh,
exactly.
okay. Thank you, ma'am.
I think there's some question on,
Sir, can I ask my question?
yeah,
Hello.
sure.
Yeah, ma'am. I have a couple of doubts. Suppose for a beginner cataract surgeon who doesn't have access to like IOL Master 700 or even a good topographer, can we rely on our refraction and the auto keratometry, this thing, auto ref, the values we obtain from that, can we use that to calculate the toric IOL parameters?
Okay. Tough question because I don't know which autoref you have. Are you based in a city or are you based in,
In a city.
you're from Bombay?
Yes.
So Bombay, honestly, and let me be frank, Bombay has a lot of these biometers which come on rent also. So if you
Okay.
really want to start out, I'm just telling you this because it's really important in your first couple of cases to be as prepared as possible, just so that you don't have any untoward surprise, which then you're later not able to understand and deal with. So in Bombay, if you're starting out and the cataract is not very hard, I would just say call one of those biometers on rent. They're all optical biometers and give you very good, reliable results. You know what I'm talking about?
Yeah. So you mean IOL Master 700 also can be
I
arranged on
don't
rent?
think they have the 700, but they have the, I don't know if it's the 500, but they have one optical biometer which is quite good. So I
Okay.
would still consider using that versus just say an auto ref, which might be my last option. If you can get that and feed in those values on the and use the Barrett calculator, that should be good enough in the beginning. And
So,
you know that the cornea is more.
if we get IOL Master 700 as a print for this thing for calculation, do we still need topography also to
If
rule
you
out
are
the
not
irregular?
expecting that it's very irregular, there's no need for you to suspect anything irregular, then no need. But
Okay.
if you are suspecting something on the cornea, scar, your retina is giving you weird shadows, things like that, you're not sure, patient has a history of using glasses with a high sill, things like that, then maybe, you can always do it. But you get a topographer even on rent. So if you
Okay.
really want to, you can do all of this in your clinic. But if you just think it's a small cylinder with a regular case, I would probably not do a topography. I would just maybe go ahead and plan the toric lens.
Okay. Ma'am, my second doubt is like after removal of the OVD underneath the IOL,
Yeah,
how do we need to align the IOL? Should we place it slightly shorter than what we have marked?
shorter, correct. Under
By how
correction.
much degrees? Like how do
Uh,
we assess that?
Maybe if not too much, you can undercorrect it a lot more also. Just don't overcorrect it because to dial it into position is much easier because if you overcorrect it, you'll have to rotate the whole IOL and bring it back again under hydro, which is like a bigger pain. Or you'll have to put
Okay.
OBD again, rotate the IOL and then wash it off and then again do that final alignment. So it's not like you, but just a few degrees of, I would say, off to how much ever you feel you're comfortable to just bring it into position. So
So
say
few degrees of under correction, under rotation, you mean?
yeah.
The
Say you
final
say your IOL, you use the optic haptic junction and you want to push that optic haptic junction into position and you're sitting, say, superiorly and the haptic is at 6 o'clock. So and you want to put the haptic at you want to put those three dots at 6 o'clock. So you might keep it a little shy of that so that you can push it into that. Don't overcorrect it. You are going to rotate at the optic haptic junction clockwise, right?
Yeah.
Uh, so a little short of that so that you can push it into that position.
Okay. And another doubt is like, suppose if there is any over rotation or under rotation, and we need to correct it post-op, and how long do we need to wait to plan the next surgery? Like how many days, within how many days we need to do that?
I would say as soon as possible you see it. So if you feel that the next day the patient has an uncorrected vision which is not being explained, you dilate, you see that the lens is not in the axis that it was intended to be, you can immediately rotate the lens. It's not going to go into the position. It's not like some surgery where the lens will now align into position by itself. So you'll have to go back and rotate it as early as possible.
Okay. No, but initially, if there's any corneal edema or something, and we defer that, so till the edema subsides,
You can
and
wait a
then
few
suppose
days.
the patient comes
Yeah.
around 1 week later, then
Yeah,
is
yeah,
it still
that's fine. Yeah, yeah. The bag is not going to fuse or anything in 1 week. You can do it a week later. I don't
oh,
think it should be an issue. But
okay?
try doing it
Okay,
as early as possible is what we
okay,
advocate.
okay. Thank you, ma'am. Thank you.
Good evening, ma'am. This is the Dr. Amod. Can I ask my question? I
Yeah,
just had one doubt.
yeah.
So, I wanted to ask if if we should have certain considerations in mind while putting a toric IOL in patients with macular disorders. For example, like any patient suffering from diabetic macular edema or maybe AMD of any severity. So, what should be our considerations in such patients for toric IOL?
Hmm. Interesting. I don't know. I've never really put a toric lens in a patient with diabetic macular edema just because I feel I don't know how much I'll be able to give them in terms of best corrected vision. So
Right.
I again I don't know. Dr. Anuj, do you have an input on this?
No, if in case of macular edema, if you are, you can always treat the macular edema and then do the cataract surgery. So yeah, in cases of ARMD, when the vision is already less, then it is more like a personal choice and what you think that you are actually giving to the patient.
Right,
Because
sir.
if the patient is not going to have the BCVA in any case, so then whether you should correct the full refractive error or offer them that, because what we are talking about toric, as Dr. Manik showed us, is the improvement in the contrast and the clarity. So if
Right.
somebody has a vision which is not going to improve because it is not related to refractive error, then yes, we may have little concession. But then uh, what I have seen is over period of time, it is just more like a rush which we as surgeons have, that
Agree, I
we
agree.
don't see the, yeah,
It
because
might be just theoretical. It might not
yeah, but
really
but
be beneficial,
Okay.
but
people do put and it really doesn't make any sense. But yeah, but cases like it's if just a diabetic retinopathy or is a macular edema, so macular edema, they do resolve. So you can always go for this, but you can
I don't know. This is just
macular
a
edema.
thought. Sometimes the macular edema itself, I don't know how much the retina contributes to your
Right.
spherical error, but it might also, I don't know how much the error that that amount of macular edema might produce in your calculations also.
Okay.
So I might just in general be wary about over-promising in such patients, because when you're sort of counseling a patient for a toric lens, you're telling them I'm trying to reduce your distance best corrected vision so that you'll be able to see clearly without glasses for far, so that you might require small readers after surgery, but trying to improve your distance visual acuity. And I don't know how usually the cylinders are not very large. There'll be something in the range of 1, 2, 3 diopters. And then to try to convince a patient with macular edema to put a toric lens, I don't know how I would be able to do that. And I don't know how
Right.
much it would help him, is what I'm talking.
So basically, we need to manage the patient expectations, and if the patient agrees to it, then we can go ahead with it. But
Yeah.
in cases where, like, for example, the macular edema can recur, so a presence of a toric IOL, does that is it a problem for such patients? Like, for
No, not
example, a
for these
patient,
premium lenses, not
right, more with the multifocal
yeah,
lenses.
yeah. It's not going to
Yes,
produce
right,
any harmful side effects like these premium
right,
lenses.
ma'am, right. Okay, thank you, ma'am. Thank you so much, sir.
So do we have any other questions for Dr. Manik?
I think Tejas has asked, can misaligned toric be corrected by glasses if patient doesn't want repeat surgery? Yeah, I think that's a good
That
idea.
is,
If patient is agreeing to wear glasses
that
after
is the
the
most you want such patients
one
only.
such patient, yeah. If he's agreeing, then very good. I don't have to break my head. Um,
Yeah.
Nancy, ma'am,
Nancy, do you want to use the mic
Uh,
for it?
uh, yeah, hello. Good evening,
Yeah.
ma'am. Good evening, sir. We had encountered one case where while closing the surgery, so while hydrating the tunnel and the side put, the IOL kept rotating. So it got overcorrected and shifted from the axis. So we had to put our surgeon, he had to put OVD and then place it back. He had to rotate the whole IOL. Then again, while irrigation and aspiration, the IOL was placed correctly, but while closing hydration, the IOL kept moving again and again. So how could we tackle that situation?
So, and two things. One is that I feel, was that a beginner surgeon or an experienced surgeon, if I can ask?
Okay, so not a very experienced surgeon, but not
Okay,
a
so I
very
do
beginner
that
also. Yeah.
because even me, when I'm a little nervous about a case and it's a slightly more premium case, I tend to overhydrate my wounds just because you want to be sure that the eye is well sealed. And this overhydration of wounds can suddenly distend the AC, suddenly distend the bag, and cause the IOL to rotate. So the trick is not to overhydrate your wounds in such cases because even a little hydration, sometimes even the hydration through what you've done with your bimanual eye and all can seal those wounds. So one thing is not
Okay.
to overhydrate, and second is of course to leave the lens a little shy of the final part so that under hydro you rotate it into position, come out, and then just slightly hydro the wounds and let that eye be. Mm.
All right.
Was the
Thank you,
speculum
ma'am.
was the speculum too tight? As in, was the eye popping out?
Could have been, could have been, ma'am.
Okay, sometimes releasing the speculum, then doing a little hydro, and then just gently releasing it from the eye, being a little more gentle in that helps. Because you really don't need too much hydro. I used to hydro a lot and I stopped hydroing so much as much as I used to earlier. Because the hydro itself can produce a little amount of cylinder in the post-operative period, just the hydro of your main wounds. And though it's temporary, it can sometimes cause you to get a little confused in the early post-operative period. So I don't hydro my wounds so
Uh,
much, as much that
I
full.
had one more question, ma'am.
Yeah.
Ma'am, so in patients of keratoconus, which has been stable over, so it has not progressed or not, progressed further. If the patient comes up with a cataract, how will we manage? Like, do we go ahead for the best corrected toric that the patient has, or do we want to undercorrect or anything
Yes,
of
so
that
I
sort?
wrote a whole review paper on cataract surgery and keratoconus. Please go read it. That is
Sure,
one
ma'am.
thing.
Thank you so much.
Published in IGO last year only. I don't remember which month, but it's published. It's a review. But basically, the rule of thumb is just when there's regular astigmatism, you can go ahead. If it's stable, you can plan your toric lens. But again, you can't under promise, over deliver because these corneas don't react to incisions and to surgery the way regular virgin corneas do. And therefore, a lot of times, a lot of surgeons I've seen, very senior surgeons, to correct these cases, use these custom toric lenses as well. So the care group, which makes these lenses of more than 10 diopter cylinder, very high spherical errors up to 40, these lenses also are quite useful in cases of keratoconus. But again, these are far and few. So, and it also depends on how good your keratometry readings are, whether you're able to get a good keratometry reading, how regular the
All right.
astig
Okay,
is, what
ma'am.
the tone is. If it's too decentered, you're unlikely to plan a toric lens, that
Okay.
kind of.
Yeah. Thank you, ma'am.
Go read the article. If you want, I'll share it with you.
Yeah,
I'll
sure, ma'am. Thank you, ma'am.
Actually, one more question someone has put on WhatsApp is
Yeah.
that in bilateral cases of can you go for different company lenses or
Different company lenses, as in Indian foreign or foreign?
that is so you can tell us everything what the
So the
combinations.
Alcon lens, if I'm not mistaken, has a yellow tinge in it, and the Technis lens is white from just what we normally use, and that's why most of the cases, even when it's non-toric, we don't mix because the two most common companies we use are J&J and Alcon, and in general, the Alcon lenses have that a little bit of yellow tinge you'll see when you take it out of the eye because they blue blocking. And no, J&J doesn't believe in that. They believe that it's not needed. So I would not basically mix and match just because of that one thing. Plus, if you've got a predictable reading with one, I would more likely put the same lens in the other eye. I would
If
not.
you have a patient who has done a surgery somewhere else, so
So if you know it's a yellow lens, just put another Alcon in the other eye. If you see it's a plain lens, just put a Technis. Like that.
so there are
Or
only two
whatever.
toric lenses in the market.
No, there's of course there's Rayner, there's Zeiss, there's all of them.
Then
But the ones which I have experience with are only these two. I have not used the Rayner Toric, though it's available in a much wider range. So I know that for extremes, some people do use the Rayner Toric. It's quite a good lens. So also, I think the haptics are different. One has plate haptics, one has those C-shaped haptics. So
right.
whether those contribute to stability or not, because Zeiss comes with plate haptic lenses. So though again, I don't have much experience with those companies, toric lenses. But between Alcon and Technis, I might not interchange them.
You mean to say a thorough history and thorough examination is necessary before going
And
to the other?
yeah, toric lenses, most of them will have their papers, insurance, something. They would have a Xerox copy somewhere. If not, you can just go ahead and put any regular toric lens, making sure that it's just matched in color. And I don't think refractive index and all that matters too much.
Sure. So anyone else? Because Dr. Manik has to attend 7 o'clock morning class. So
Yeah.
I think
Now 8 o'clock at SSCI.
okay. That's Mumbai Standard Time.
Yeah, Mumbai stand. They were like, if it's 7 a.m., people will revolt. So it's now 8.
Okay, okay. I think that was like really amazing, and we had good interaction. So we had over 80 people joining, which was a great number because we just updated just 1 hour back, and we are hoping to catch you up again with the biometry.
I know, sorry, my apologies. Very, very sorry to everyone
But
because
Toric was also pretty hit in few groups. It was topping the charts.
okay, I'm sorry. I will prepare for that one next time and come. And thank you, Anuj, so much. This is a fantastic platform you created for learning and teaching. And I joined so many classes even just as a listener, and it's just fantastic learning, especially the ones on these offbeat topics like FRCS and fellowships, and these kinds are so interesting to listen to because you get other people's perspectives on how these situations are.
I
Very
think it's
good.
all thanks to the speakers. So thank you again, and we'll catch up again. Thank you everyone for joining, and good night.
Bye. Good night.